Thanks. Hi, everyone. Welcome. We continue to connect in this virtual space. Sadly, hope to connect physically with many of you soon, but I don't know when exactly that'll be. But hopefully, everyone's staying positive. I know it's getting cooler across the country of the U.S. At least. I know we have even some global guests as well. So welcome everyone from everywhere, and wish everyone safety and happiness. And excited to introduce my friend Katherin LaFaver from Chicago. She's had kind of an interesting journey to getting to Chicago, which she'll share with us. But she's really been doing some amazing work in this field of functional neurological disorders, and really have had some great discussion with her about various types of patient approaches. And I think we share a lot of interest both in supporting other women in neurology. She was really one of the founding members of the Women in Neurology group and has brought many of us together. And then just trying to support each other through the pandemic. Through some virtual happy hours and some other things. So we not only tell all of you out there to keep connected, but we also do it ourselves as clinicians. So excited to see you, Katherin. Thanks for taking the time on a Friday. And I love your virtual background there. So tell us a little bit about yourself and how you got to the passion of Parkinson's and being a movement disorder specialist, but also this newer sort of interest in functional neurological disorders.
Thank you, Indu. Thank you, first of all, for the invitation and having me. And it's fantastic to see here well over 100 people join already. So thanks, everyone, for joining and coming a little bit on a journey to some undiscovered shores here. You see the Lake Michigan here in my background. So first of all, congratulations, Indu, on just putting together this fantastic series. I've kind of tuned in a couple times in the spring, and it's just been amazing what you've pulled together and really connected people across the shores, across the US and beyond. So it's been really fun to see that. And for some of my patients with Parkinson's, with other issues, it's been interestingly a time where some have found it easier to get support from support groups, exercise classes, if they especially live in areas where are not urban, right? If you live a little bit outside of the cities, it's not as easy to actually find access to support groups. So I think, so definitely not saying that this year has been easy in any means, but hopefully some of that positive momentum and really connecting people, hopefully some of that we can take with us beyond COVID. So so with that being said, so yeah, a couple words about myself. So if you detect a little accent, that is not your imagination. So I'm a German national. I went to medical school in Germany in Freiburg, actually. And after medical school, me and my boyfriend at the time were just sort of adventurous. Or actually, during medical school, had spent some time in the U.S., had some connections there. So I was actually in LA for 2 months during medical school, spent some time here close to Indu. And I was in Chicago, and we decided to do our further medical training in the U.S. So I did a neurology residency at Mayo Clinic, which was really a wonderful place to train at, and really their motto is always the patient comes first. And hopefully I'm always going to keep that with me wherever I go. I then had the very good fortune to be accepted for a movement disorder fellowship in Boston at one of the Harvard teaching hospitals, and also spent some time at the National Institute of Health, doing mostly some research there. And was practicing at University of Louisville in Kentucky for 6 years, and then just last summer joined Northwestern here in Chicago. So I'm a movement disorder specialist, and have spent about half my time in clinic seeing patients with Parkinson's disease, of course, dystonia, other movement issues. But I do have a very long-standing interest. Pretty much since I started my training at Mayo about 10 years ago, in sort of overlap with what is called now functional movement disorders. And we'll talk more about that. But essentially what that means is that those are disorders that are not primarily due to chemical dysfunction in the brain, such as dopamine lack, but are often triggered by psychological and emotional stress factors. And there's just been so much interesting research coming out of this, I think in the past years, how this really affects all of us, whether we have functional movement disorders, whether we have Parkinson's, whether we don't have a diagnosis of a disorder per se, but we all have our good days, our bad days, and how emotions play into this. I think it's just an area that is still not enough recognized.
Absolutely. Yeah, it's really been pioneering work that you guys have done, and you put together this new society, and it's been amazing to see already how productive you've been. So congratulations. I know that you have some slides for us to teach us a little bit, and I think there's already even been some chats about what is this that we're talking about. So maybe you can clarify a little bit and help us understand and take us on this journey with you. And I think it'll be quite outside the box. I think today will be not your average support group meeting, and not your average talk that we would give it, a plenary session of a movement disorder meeting. So stay tuned. We'll sort of take you on this journey and learn together.
Yeah, well, thank you so much. Can you see my slides?
Yep.
Okay, wonderful. Yeah, like I said, I was very excited to have so many people register because most of you, I would imagine, don't really know what this is all about. And so I'm hopefully going to shed a little bit more light on this. And this is definitely not going to be a slide heavy talk. I just want to set the scene a little bit, get us a bit more on the same level to really understand what I'm trying to talk about, and we can have more of a discussion. So, and this is really goes in a couple different ways. And like I said, there is something called functional movement disorders, and we'll talk about that first. But secondly, I do believe that what we call functional symptoms, and again, we'll define that a bit more, ultimately affects many of us. And it's often overlapping with other neurologic conditions, such as Parkinson's. So what are these functional movement disorders? So how we define it is that people can experience one or more symptoms of altered movement control. So altered movement control that is different than Parkinson's, stroke, things like that. People can essentially mimic other neurologic disorders, and they often have tremor. So just like in Parkinson's, they can experience shaking, and often not only of one arm or the hands, but it can be whole body shaking that can almost look like convulsions or seizures. These problems can cause gait disorders, abnormal posturing of limbs, and really can be a combination of a lot of different symptoms. Different a little bit to Parkinson's disease, they often are fairly acute in onset and can have quite variable symptoms over time. The treatment for functional movement disorders is still not optimally established, and oftentimes symptoms can be chronic. And so how common is this? Is this really worthwhile talking about if this is some obscure, rare thing? Well, interestingly enough, despite almost no one having ever heard of that term, as neurologists and especially movement disorder specialists, we are definitely all very attuned to this issue. And in several studies kind of looking at academic movement centers, it was at least 3 to 5% of patients with this diagnosis. It is a little bit difficult to actually get really reliable data on how common this disorder is. And one of the reasons is it goes by a couple different names, and I think I have another slide on this. But in the past several years, most of us treating patients are using this term functional movement disorder. Now, interestingly, there was one study in Scotland, and I didn't reference that here, but what they did is they over a year and a half, they asked all neurologists after they saw patients for the first time to put the diagnosis down on like a research questionnaire and say, were these purely neurologic disorders such as Parkinson's or MS, and again we're getting a little bit in the difficulties of the definition, or were these mostly issues where psychologic factors played a huge role in your opinion? And you know, we could really argue, you know, I stumbled over a little bit when I mentioned purely neurologic disorders, because as you all know, as people who have Parkinson's, as physicians who treat people with Parkinson's, when we talk about psychologic symptoms and stress and things like that, we know that at least 70–80% of people who have Parkinson's will also be dealing with things like anxiety and depression. So there is a huge overlap between what we traditionally call neurologic and you know, psychologic symptoms, and the brain in a way doesn't have separate boxes to distinguish between these things. But for some patients, the, in a way, mind can be the primary reason why they present with neurologic symptoms such as shaking or gait abnormalities. And again, I'll have a couple more slides to go into a bit more details. But this was just to say that this problem that we're talking about today is not a rare thing. Although, you know, I'm assuming all of you tuning in today, this is obviously a Parkinson's support webinar and information, education. So I would imagine that you either have been receiving a diagnosis of Parkinson's disease or have a loved one, a family member, friend, and want to learn more about it. But it is possible that for some of you, over time, this diagnosis might come up, and it's at any rate good to know about this. So despite this being so common, there really is a huge lack in public awareness and in research in this issue. This is a huge issue for the economic healthcare system because, as I mentioned before, these problems are often chronic, and people will often be disabled from these issues. So you might still be scratching your head and saying like, well, what are we talking about? So over the years, many different names have been used for what I now call functional movement disorder. And this goes back to, you know, sometimes way back, women were often labeled as being hysteric. And obviously this is colloquial, still used to kind of label possibly problematic behavior. But in the medical literature, the term psychogenic movement disorder was kind of sticking for a long time. And again, what that means is that for some people, some patients who we see as physicians, that psychologically driven problems seem to be the kind of a main issue causing the healthcare problems we're seeking help for. Other terms being used, you know, would be psychosomatic or stress-related. But how it all relates to Parkinson's, as as movement specialists have become a bit more attuned to these issues in some patients. One of my friends and mentors here, Dr. Alberto Espay, did this interesting project a couple of years ago. So what he did is he reached out to lots of his colleagues and was asking, do you have any patients in your practice that have been diagnosed with Parkinson's disease, but where you also feel that functional symptoms, or I'm just going to abbreviate it or kind of say that is also psychologically driven symptoms, have a main cause or a main cause for their symptoms or for their disability. And so this was actually a case series that then came together of over 50 people, interestingly, that often showed overlapping symptoms. And this is, again, not sort of a big prevalence study. This was really more anecdotal. He was asking some colleagues, have you encountered patients that have sort of an overlap between proven Parkinson's disease, but then also more functional symptoms that are very related more to stress factors? And how would we be able to tell the difference? Well, and I didn't actually include too many slides on this, but there are diagnostic features how we will be able to tell the difference. And obviously, we're kind of most interested today talking about Parkinson's and as these functional signs relate to Parkinson's. So some of the risks and trigger factors for functional symptoms. This is an issue that comes up more often in women. It comes up more often in people who've had adverse life experiences, and that can go back pretty far. That can go even back to childhood, early life experiences, or being more recent. People who have already other neurologic disorders and basically medical stress induced by medical conditions are at a greater risk for developing this. Lack of family and peer support, history of mood disorders would all put people at a greater risk for this. And then stressful triggers, and that can be both physical or emotional stress, so acute pain, head trauma, stressful or challenging life situations, lack of sleep, acute anxiety can all trigger functional movement disorders. And so how do we tell the difference? Well, so with Parkinson's disease, we have the history and examination that many of you might have heard. Well, Parkinson's is a clinical diagnosis for the most part. And on the typical examination, we can see people have stiffness or rigidity, slowness of movements, tremor, the shuffling gait, the stoop posture. Now, interestingly, functional movement disorders can often mimic Parkinson's features, but importantly, on detailed examination would not cause rigidity and not cause bradykinesias. So would not have the typical stiffness and the typical slowness of movements that are driven from the lack of dopamine. But in a way, it's more of a brain that can slow down movements, even with normal dopamine levels. So it's a very puzzling condition to really wrap our heads around. Ultimately, sometimes people are very confused when we do give or do make a diagnosis of a functional movement disorder. And, they sometimes might ask me or some of my colleagues, well, are you trying to say this is all in my head? Or, meaning in a derogatory way, do you think I'm just imagining this or making this up? And that is certainly not the case. But the brain is, as we all know, very complex, and we're still not completely understanding the brain. But what we do know is that a lot of different things go into planning our movements. And we have here in purple the motor cortex. That's where all movements start, where all movements originate. But it's not so simple. So from the motor cortex, movements go down, get input from the famous basal ganglia that are not functioning normal in Parkinson's. And then there's a lot of feedback and crosstalk with all these other lobes, giving experiences, giving feedback, giving input from all the sensory information that people get. And so while in Parkinson's, we do have the low dopamine levels as a cause for much of the abnormal movements that you experience, the functional movement disorders, we can have disruption of these movement patterns due to psychological influences. This is actually a figure from a paper on Parkinson's disease that demonstrates that movement control, so motor or movement control, and emotional control are extremely closely connected. And so this is how this topic really pertains to all of you, because as I said, we are learning to understand more about movement control and in functional movement disorders, but some of the insights we're gaining are really applicable to all of us. So here is, I kind of already mentioned some of these structures, but here is a loop demonstrating movement control. So like I already mentioned, the motor cortex is where movement control, movement planning starts. The signals get sent to the basal ganglia, and those are kind of the same areas we try to influence with Parkinson's therapies, including deep brain stimulation surgery for those of us who have ever heard that or might have that treatment, and then get sent back through the thalamus, which is sort of a sensory input station before signals get sent back to the brain. So this is the movement control. And I just think it's very, very fascinating to see that our emotions have a very kind of similar pathway. And so here we see some of the so-called limbic structures which control emotion, and they too get sent to the same basal ganglia area, get sent back through the same sensory relay station and back to the upper kind of cortex. So seeing these kind of, for those of you who are engineers or kind of familiar with sort of these kind of circuits and crosstalks, you can very easily imagine how there's a lot of interaction between these different circuits. And knowing these parallel circuits can also be a good explanation why emotions can influence the motor system. And so maybe this is kind of just a good point to for me to kind of stop and see what questions people have, and also maybe have Indu kind of share some of her experience. But to me, it's just when we ask our patients, how much does it influence you when you have a bad day? Or, I mean, I think all of us, and especially when I see any patient with Parkinson's disease, will say, if I do feel anxious or stressed, or if I have had lack of sleep, my movement control is usually much worse. My Parkinson is much worse. And, part of this could be explained through this crosstalk with emotional circuits. So I don't know, Indu, do you have did I confuse everyone?
No,
How are we doing so far? Maybe
I think that's great.
maybe you can add some things.
Is this your last slide, or do you want to stop sharing screen, or should we keep this up, or is there more?
Actually, yeah, that's a good point. I think I actually only had one more slide, and I could stop sharing. So yeah, so I think in addition to, well, I talked a bit about parallel circuits. So it's more complicated than that. It's not just two circuits. It's really a lot of information that gets integrated in our brain all the time. And, this is more kind of an abstract figure here, but I think it's just a good reminder. Movement control, again, you all are very interested. Well, how can I treat my Parkinson's optimally, right? How can I make sure I function well every day? And so, of course, as neurologists, we will talk a lot about medications in the office. We'll talk a lot about, well, how are we going to optimize the carbidopa, levodopa, or, other medications you're on. But I think it's also very important to realize that there are many, many other factors that will influence your good days and your bad days beyond just the medications. And one of the reasons why this is that so many things influence our brain and influence ultimately movement control as well. So we have our emotions. We already talked about that. Feeling anxious, feeling sad. Even for people who do not have Parkinson's, when you feel really depressed and really sad, people often walk stooped over and move slower. So depression itself can sometimes even be mistaken for Parkinson's. And the opposite is true too. People who have a very positive attitude feel, very supported and feel very good. You generally walk faster. You generally things come easier to you, not just mentally, but also in regards to movements. And then other factors certainly can influence movements as well. So those of you who have ever experienced freezing of gait might know that rhythmic music can be a huge game changer for this. Music also influences our mood. Then visual input, input from, so this is kind of meant to demonstrate sort of a feat, so the tactile input from our environment. All these things ultimately interact and shape our experience. And for the purpose of today, again, we're talking mostly about the influence of emotional factors on movement control, and just really stressing the big importance. So I think it's just a good concept to know about and to know a little bit about the backgrounds. And as it pertains both to everyone who has Parkinson's or another movement disorders, but then also for this specific concept that for some people, it might look like they have Parkinson's, but after some more workup, and we can talk more about who these people would be. For some people might initially be thought to have Parkinson's, but ultimately it turns out that functional movement disorders is the more correct diagnosis. So yeah, so with that being said, I'm just going to show you again my nice view here from our hospital, and happy to stop sharing my slides so we can all be a bit more interactive.
That's awesome. Well, thanks so much. That was a great slide set. And I know it wasn't an easy concept. I think, just so people know, we've been Katherine and I went through the topics that we've covered on the series, which are a lot of topics actually all to date. And we were trying to, find something that she could speak to. And, we kind of came up with this together, and it was kind of out of the box. We wanted to kind of just put out sort of what we know about functional neurological disorders, and then sort of discuss a little bit about what we've been seeing with our Parkinson's patients with that study by Dr. Espay, as sort of the focus, but then, just sort of open it up a little bit. But I think the chat has really been, this has been resonating in the chat for sure. I think, just to sort of share a few things here. Kelly writes, wow, just wow. Glad and thankful to hear and have someone to finally put all of this into words, proof. Got to show how even the circle of care plays a larger role than many people realize in the care of people with Parkinson's. So I think, I think there is definitely, a big interest in our population of patients. And I think, with COVID and the stressors that many of us as doctors and parents, and, just trying to balance everything, and the additional stressors that I think many of us as healthcare providers are feeling, I think many of us are realizing that this can really take a toll on our mental health and our physical, sort of feeling of, being able to get through the day and all the things that we've all sort of been, the heaviness and things that and the stress that we've been carrying. So I think this is all very interesting, and definitely resonating with the group here. So a couple of things, maybe just starting with a couple of comments. So one is, there's a question or two about trauma. And I think this was something that Katherine, you and I have been talking about even before this. So there's definitely, I think, been an interest, and you put up a slide or two about, adverse events, for example, that can, influence people, with some of these disorders. And And trauma, I think, is something that you and I have both been really interested in learning about. And there's been a push, at least in the state of California, to understand how trauma with as measured by the ACEs scores, and maybe we can link that. That's ACES. These are early childhood adverse event scores, and really look at things that happen to people before the age of 18. There's a way you can come up with your own score. I think it's scored out of 10. And the current Surgeon General, her last name is Burke Harris, Dr. Burke Harris, has been doing work on this. She's a pediatrician who was really looking in San Francisco at groups of kids that were coming in as she was treating them in inner cities and seeing how these adverse events were affecting health. And then there's been studies that look at, the eventual disease in people that have been exposed as children to different adverse events, and eventually seeing that it really can predict a lot of things like heart disease and other sorts of issues. There hasn't been a lot of studies, as we've talked about, in either functional or neurological disorders or Parkinson's. I think there's been a little bit of studies around Alzheimer's and things like that. So I think, Katherine, you and I have been talking with a few colleagues about trying to collect some of this information. And I think it sounds like from the chat here that the patients are also interested in learning about what these may have had to do with their own disease or the disease of their if they're a caregiver, their loved one with Parkinson's. And so maybe, Katherine, you can just speak a little bit to trauma as it affects functional neurologic disease, and if you have anything to say about the Parkinson's population as well with trauma. And that's really the emotional trauma. So not a physical trauma necessarily, but it's sort of these emotional traumas. And in that scale, it talks about, did you have a parent that was incarcerated? Were your parents divorced? Did you undergo sexual abuse or physical abuse, things like that as a child? So those are sort of what the score includes.
No, absolutely. And so before I come to this, I just wanted to actually say a couple more words, because I kept seeing sort of comments fly in here too. So someone mentioned, a DAT scan can be helpful to tell the difference. And so that is true. And I didn't mention that specifically, but yeah, so oftentimes when we see patients who have a lot of Parkinsonian features, but maybe not quite typical, and so, so some of the warning signs or these atypical signs that might be telling me, this could be a functional disorder. So some of these things are, if the disorder starts pretty suddenly, it's not always the case, but if sometimes I've seen really people who just over the course of weeks develop very severe tremor, and, not to say that can never happen with Parkinson's, but that's a kind of a red flag a little bit. If symptoms start very suddenly, lead to fairly severe symptoms very quickly, again, sometimes just in weeks, and then often do not respond to treatment. So people get started on the typical carbidopa levodopa and have not a good response, or need higher doses of medication in a very short amount of time. And so none of these things are 100%, but there are, like I mentioned on the exam, there are differences. So I certainly don't want you to go all home today, or well, you're already home, sorry. I don't want you to leave this talk today and kind of scratch your head and say, oh my gosh, how do I know, could this apply to me or someone I know? I would definitely trust your neurologist, with the diagnosis, because, we are trained to diagnose Parkinson's disease. But it is surprising to me that, I see patients now and people now know that I have this special interest now. So I certainly have a referral bias, because I get a lot of patients referred now where people are wondering, could this be a functional neurologic disorder? And sometimes this happens, that someone was treated for Parkinson's for a few years, or just a shorter amount of time, and again, there's been questions because the medicine isn't working, they're still very disabled, and so sometimes that comes up. And oftentimes, if then be an examination, so what can be very helpful is to actually see the patient without medication in the morning and do a detailed examination. And if we do not find the typical rigidity and bradykinesia, so this typical slowness and stiffness, then that would be the things that would raise suspicion. And often a DAT scan can be helpful, because a DAT scan is showing dopamine deficiency in Parkinson's and would be expected to be normal in functional movement disorders. So with that being said, so I think, again, I think that, we were interested to talk about this topic today because even if it's just one of you listening today, that might be an issue that has come up or may come up, but there is a, that diagnosis might be come up as a possibility. Again, but that would certainly not be the majority of you. But again, that second part of the equation, that as we're learning more about psychological effects on movements, we're just learning really, this can to some extent explain some of the variability we see in our day-to-day function. And that aspect, it really applies to all of us. So how does trauma come into this equation? Well, I think that's, I talked before, there's really not much recognition in the general public, even among healthcare professionals, how profoundly our past experiences shape our lives and healthcare outcomes. So Indu was mentioning there has been the adverse childhood experience study. And they looked, it kind of started actually in San Francisco. Nadine Burke-Harris was this young pediatrician who was very idealistic and basically thought, I'm going to make the life better in the poorest parts of San Francisco. I'm going to go there, serve as pediatrician, and really, really help these patients to have better lives. And after she worked there for a while, she saw the kids for their asthma, for infections, and but kind of just still noticed, despite helping with the medical issues, overall, there were lots and lots of issues that led to poor behaviors, poor healthcare outcomes that she couldn't really target with the usual things that, pediatricians do. And some of these things were affecting, mood. And what she was finding out is, a lot of people who were living in unstable situation, who had parents or who had siblings that had mental health issues or drug abuse issues, and it affects not only our sort of social life, but it can have adverse health consequences. And we know that people who have adverse childhood experiences, and again, that's not just very obvious physical abuse or sexual abuse, but even things like having parents who are not as present, feeling neglected, dealing with those types of challenges can lead to a higher risk of diabetes, cardiovascular diseases, obesity, so many things that we don't associate necessarily with childhood stress. And that really continues throughout life. So I think it's something we just don't often realize, like how our day-to-day stress factors ultimately influence our illness experience as well, and might just affect how well we feel from day to day, even if we're not, a lot of people say, well, I had stress in my life, but I'm currently feeling good. And that might very well be true, but we do know from lots of animal studies, from other research, that stress experienced early in life will leave traces on the brain. So there's a famous study where they studied rats that were abandoned by their mother as young pups, essentially, and then let them grow up and look at the size of certain brain structures. And they had a much smaller size of their hippocampi, of the structure that deals with memory. So things will leave traces in our brain. And we often talk about not just one like single brain structures, but more about brain networks. And that's kind of what I showed before. There are, there's the brain really functions as a constant chit chat between all the different areas of a brain. And then I showed the emotional and the movement circuits. And so it's not surprising that our past experiences shape our life in this way. But I still think that it is surprising probably to most of us, or we don't think about this every day, that emotions, emotional trauma, stress related things, not just impact our mental health, but also our physical health. I think you're still muted.
Yeah,
Yeah.
sorry about that. Yeah, my phone was ringing over here. So I think, I think I'm reading the chat here. There's sort of a lot of different people sort of resonating with the concept that, a bad sort of a stressful day or emotional upset can really affect them physically. And I think, sort of the wonder of Parkinson's for me, as somebody who I think is quite an outside the box thinker. I really do enjoy talking to patients and learning anecdotally, and believe, if you're my patient and you're experiencing something, then that's a real experience for you. Trying to understand that from, where is that in the body? Is it, at the basal ganglia level? Is it where in the cortex, or what's influencing? Are there chemicals floating around? That becomes a little harder to understand. But I think, my thoughts are from just hearing these messages is that, this disorders of functional neurological disorders is a group of disorders that 3%, 5% of us, in my practice or your practice are seeing in specialty movement disorder clinics. Probably you're seeing a little bit more because this is what you're seeing mostly now. Parkinson's is something that is a clinical diagnosis that many of us who are movement disorder doctors are quite savvy at picking up. If you have a diagnosis, and you're getting treated and you're responding to levodopa, that's very, very likely that you have 99.9% of the time that's going to be classic Parkinson's disease. You don't really need a DAT scan unless there's some question in your doctor's mind as to what the diagnosis is. I see in the chat that some people say that their insurance isn't covering. It's certainly not something that I order. I think the last time I ordered one was maybe 4 or 5 years ago. It's not something that I order in any sort of classic level. I don't know how much you're ordering DAT scans, but what this basically shows us, it's a functional imaging study, shows us that area that you showed, those sort of the basal ganglia, which were those sort of curvy things on your slide that, if people go back and watch the videos or get the slides, they can see that are sort of lower down. You showed the cortical projections and stuff. That area, is not, the dopamine is not being uptaken there well. The dopamine transporters are messed up. And we see that as an abnormal image on that type of scan. It's not something that we need day in, day out to treat Parkinson's patients, but in a question, it's something that we can order, and maybe a piece of information that may help us to kind of make the diagnosis. But I think the more interesting issue that may help the group at large, and maybe all of us at large, even who don't have Parkinson's, is how much the mind and the body are related. And I think that's kind of really interesting to me to see how if people are anxious, if people are stressed, if people are feeling lonely, or these other things that may be modifiable, how that can really impact our physical function. And many patients will say, I was doing really well, and then I heard some bad news, or somebody upset me, and I just couldn't move for the rest of my day. I felt like my pills, none of them worked, and it wasn't until a day or two later that I really felt like I was back in line. And I think patients tell us this day in and day out, and people are talking about that in the chat, is sort of the effects of anxiety, the effects of having, when stressed or emotionally wrought, my symptoms absolutely flare up. I think that really is resonating with a lot of people in the chat here. Someone here describes a 54-year-old woman, slight tremor and slight decreased arm swing, got diagnosed for Parkinson's 9 months ago. Extreme anxiety after the diagnosis made the tremor 100 times worse. Levodopa was prescribed without much help. This is all very fascinating, but where does one go, if one feels that there might be a functional movement disorder sort of overlap, in that type of case is the question. And somebody else asked also similarly, if we realize that there may be these issues in some of our patients, I think a lot of doctors Diane writes, how are these emotional or anxiety disorders safely treated? Neurologists, specialists want to throw this over to the psychiatrist, who then over-medicate dangerously in certain people's experience.
No, I think that was actually my next point too, to kind of bring this a little bit from like just knowing about it to sort of like, well, what can we do about it? And especially, again, I definitely want to stress that I think in the group today, there's like I said, maybe one person, if that, who that pertains to, who has been maybe misdiagnosed at some point with Parkinson's, and then over time, as the symptoms sometimes become clearer, the neurologist might suspect, this really doesn't fit, and maybe this was misdiagnosed. But I think for most of you, you shouldn't kind of leave here after, all confused and say like, oh my gosh, well, what's going on? So Parkinson's disease itself, as you all know, can cause a lot of day-to-day fluctuations. And as the disease progresses, as you lose more dopamine, the medications often need to be adjusted, because the medications don't last as long, and that can be a very, very difficult situation where you are sort of having the extra dyskinesias and having a lot of off time and feeling frozen. And so those are all obviously real physiologically explainable experiences. However, there is a lot of variability between people. For some people, they'll not experience as pronounced ups and downs. Some people, they'll experience very, very disabling off symptoms, and often as going along with severe anxiety as well. And again, I think that's kind of their sort of a connection. And I think it's just very powerful to realize the mind, for these people who have these functional disorders, the mind and brain can be so powerful to produce tremors and gait problems that look like Parkinson's, although there actually is normal dopamine. So there's more than just dopamine that all kind of shapes this experience. And so how can we learn from this? And what can we do? And what can you do if you have symptoms that don't seem to respond well to medications? And so there's a lot of different strategies, of course. And I know that, Indu, I know you've already had other talks on the topic of anxiety and mood, but essentially what it comes down to, so is trying to find a better balance for our brain, where some of the anxiety and mood issues can be more stabilized. And there's certainly not a cookie cutter treatment that fits for everyone. There needs to be a comprehensive assessment to decide, what are the factors feeding into this, and what is the best treatment. So it might be interesting to hear about how do we help patients who have these functional problems that are mainly triggered by emotional unsteadiness. And it's more complicated than that, but I don't want to get too technical. But many of these patients can actually benefit from rehab, the physical and occupational therapy, just like you with Parkinson's. And so why that is there can be retraining of more normal movements. So just like you do the big and loud therapy, where you can teach your brain to move bigger again, similar strategies can work for patients with FND as well. Now, the sometimes more difficult part is the emotional treatments. And with Parkinson's in particular, many people can benefit from medication. So if you are experiencing a lot of anxiety that the Parkinson medicines alone are not helping with, many patients can certainly benefit from antidepressant, anti-anxiety medications. But the most powerful is really then there's additional interventions as well. And we all know, again, our experiences is shaped by so many things. So if you take medications, but you are in a very, very unhappy relationship, you're probably still not going to feel great. So the answer really is different for people in different situations, but often psychotherapy can be helpful for many people. And other ways, more widely for any of us, doing things like mindful meditation, relaxation training. There's many great resources, and I'm happy to share ones that I usually share with patients. For example, the Headspace or Calm apps, very good resources. There's 10% Happier, which we all kind of love to be. But that has been a wonderful website from Dan Harris, who's a news anchor who experienced an online panic attack while he was anchoring or reporting a show. And in that wake has become very interested in mind-body interactions and runs now this big website, 10% Happier. They have done fabulous work during the COVID pandemic this year, and they do a lot of live meditations, guided meditations on almost every weekday afternoon. They have podcasts, they have lots of resources. So I've actually recommended that to most of my patients, regardless of the other diagnosis. So how is that helpful? Well, like I mentioned, there's a lot of crosstalk going on in the brain at all times. And the more we can have calm influences on the brain, we can try to reduce some of the increased stress response. So it can be very helpful. And I often tell people, rather than watching another hour of evening news that's just going to get your stress response up, really can be very helpful to turn the TV off at a certain time and do something calming, like listen to a guided meditation. Can be much better way to end the day than falling asleep to the TV. And these type of treatments can, not just benefit someone with a functional movement disorders, but probably all of us, and especially this year.
Absolutely. I mean, I think with the pandemic, it's been stressful. I think that people are feeling, disconnected from even being their normal mechanisms of talking things out. I think, a lot of, human interaction is about having a stress, something happened at home and you might go find a friend or, meet up and talk about it, with a neighbor or something else. A lot of those things are disconnected. So people are harboring these emotions. If you are stuck at home with, as a caregiver with your loved one with Parkinson's, it just is a lot. So I think that, taking that time out for exercise, I think can really help with some of these circuits, as you were mentioning. Meditation can help. Yoga, things like that can be very helpful. These mind body approaches, Tai Chi, people have asked about. I think meditation, even biofeedback, which is, also, I think, part of this whole similar sort of mind body approaches can be helped in that regard. I think are all very important, but, even just talking to someone, maybe talking to a friend, talking to a neighbor, if you feel like, the stress levels are high, reaching out and seeing if there might be a therapist that is available. I know a lot of psychologists are very busy, just talking to, people in society, not just Parkinson's patients and even healthcare providers. A lot of people are using those resources. So I think that, good old talking to a friend about, I feel this way, and, sharing a shared experience of feeling stressed, I think can also be quite therapeutic. So I think, we definitely do understand, I think in the modern generation of neurologists and movement disorder docs who, Katherine and I are both in, who really, I think a little outside the box, we're attracted to Parkinson's because it is such a mix of, motor issues, but also these non-motor issues, and sort of the interplay between these things can be very, disabling for our patients, but also I think fascinating as sort of this really in your face proof that I think the mind and the body are very connected, and hopefully we can get more understanding of some of these approaches as Katherine was saying, around meditation and using these apps and disseminating this knowledge. So they're not unfortunately sponsored by drug companies and surgery companies, and so there's not a lot of data out there. We're sort of trying to do research and find these ways to get patients to connect with some of these things, but I think they're just not popularly known about. And I think we do have a great sense that this, if you're a patient with Parkinson's and somebody wrote, if you have a face plant or something bad happened, I can't remember exactly which of these, bad constipation, even if these can also all affect your physical state so much. And I think we absolutely see that on a very regular basis. There's also been some questions about, yeah, somebody writes here, Ken writes, I maintain that Parkinson's disease is a misnomer. I think it should be called Parkinson syndrome. And for those of you guys who are, I know that, see, there's a lot of DAT scan questions here. Probably hard to answer all of those in this setting, but we're going to try to get John Stossel, who is a great imager, and he can spend the whole time around here. But yeah, I think Parkinson syndrome, I mean, it is kind of a conglomeration of various, symptoms, and so I think that's absolutely.
I think that's very true. Yeah. So I keep telling people, your Parkinson's is not the same as your neighbor's Parkinson's. It's a big spectrum. But maybe I really wanted to make a plug to destigmatize mental health care. And why do I say this? The older I get, and I'm in my early 40s, so I still, I'm still middle aged, I guess. But, sometimes when you're in your 20s, you just think, oh my gosh, there's some point in your adulthood where you have it all figured out and, kind of have it all together. And the more I get older myself, you're just sort of, realizing, gosh, how difficult it is to balance these things in life, right? And it never ends. And the more I talk to my patients, and not just, oh, how's your Parkinson's doing? Oh, you're doing good. Okay, we'll see you next year. But the more you really ask what's really going on, there's so many heartbreaking stories, and people carry so much in their daily life with them. Well, it's not surprising that it does affect your physical health. And again, I think there's just not enough awareness how much stress and how much trauma we all carry. And as an example, I'm just going to tell you, I was just talking to a gentleman this week who basically said, he was going to bed every night thinking about a way how he could not live anymore and make it look like an accident. And you would be never able to tell just meeting this gentleman on a superficial basis, because he was, holding down a very successful job, etc. So never guess what people experience behind, in by themselves and behind closed doors. And again, I just think supporting people in these sometimes very, very difficult journeys is so important because, again, we don't always realize how having these difficult life experiences, having ongoing, untreated depression, anxiety, really impact us. And sometimes it's still very stigmatized to seek help and to see a psychologist, and being maybe told, oh gosh, what's wrong with you? Are you weak? It's seen as a sign of weakness, and it absolutely shouldn't be. So, again, so many times these functional symptoms, it's not an easy answer. A lot of these things occur, but people just have incredibly life stories, and sometimes we do see this in people occur for the first time when they are getting older, and there's sort of a compensation kind of mechanism is lacking. So I'm just humbled every day by the difficult life stories that people often go through, and even if it's thing that might not be as drastic, it's just there's no stress factor that is too mild. There can be lots and lots of things And yeah, someone's just making a comment on PTSD. I think it's very true. I mean, we used to think of PTSD being an experience of people coming from war, but we know more and more. You know, even having been in a bad car accident, having had a stressful job where you hear and experience difficult stories, you know. Can be even just being in a call center, you know, you listen to people complain all day. I'm not saying this is all causing PTSD, but you know, we all deal with a lot in our everyday life, and that does leave traces. And we're just I think starting to address these issues better. And again, as it pertains to Parkinson's, is not just the dopamine medicine we need to worry about. There's much more to our life experience. And I know, Indu, you're doing some great work on this. And I just hope that this was a bit of a glimpse in some other factors that can influence our movement experience and might be to some degree relevant to all of us.
Yeah, I mean, it's complex, and I think that we all have our stories, and I think that just learning more. The more I learn about trauma, the more I learn about PTSD, the more I learn about many of these things. It's just fascinating. But I think keeping an open mind to the experience, being able to share the common human experience of what all of us are going through right now, which is quite stressful, I think is very helpful. And I think sort of reaching out if you need help. And understanding sort of that we may not have one answer, and that if we end up seeking the help of a psychiatrist, it's not because we think it's all in your head. It's that we think that there may be some, we actually, at the VA where I work, we actually have a psychiatrist that sits next to me, and we in the Center of Excellence that I run have hired a psychiatrist because we believe that Parkinson's is so so connected in the mind and the body, and that we can work together to help our patients. So thank you so much, Katherine, for your continued work and your passion for this very fledgling area. And I know it's been hard to define this and help get the word out, but I know on a global level you've brought a great number of people together, and I think this is just the beginning of this dialogue as it affects Parkinson's patients as well. So I do hope to continue to learn from you and hopefully bring back some of these nuggets of knowledge to our patients so that we can help their quality of life. And as you were saying that about Parkinson's patients, I was also thinking about the caregivers as well. So a shout out to all of you at home who are also, caring so beautifully for our patients, and, being the sort of eyes on the ground there. And it's not easy, especially in a pandemic, without, rest and relief. I applaud you all, and hang in there and make sure that you're taking care of yourselves as well. So, so thank you so much. Yes, so I think there's many positive comments here, Katherine. Hopefully you can read them later, but I think these guys will send them to you too. But we're at the top of the hour, so I will send it back to you, Anissa. Thank you for hosting PMD Alliance.
Wonderful. Thank you so much for sticking with us here, and have a good rest of your weekend.
Thank you, Dr. LaFaver, Dr. Subramanian. It was great seeing everybody. You should join us next Friday because we're going to be talking about music in the brain with Dr. Subramanian. Until then, have a wonderful weekend, and let's wave goodbye to each other. Thank you so much. Bye-bye.
Bye.